Afternoon, everybody, Chairman, and I'm really thankful to Dr. K.K. Agarwal for giving me the opportunity to speak. Um, yeah, I'll try to be brief because I actually understand the constraint of time. I would outline my talk on these headings. Basically, there are four types of cardiac valves we use: bioprosthetic, prosthetic, homograft, autograft, and the results and the selection of the valves and the recent advances. In the aortic valve, as we know, the commonest etiology here in India is rheumatic, and it is followed by a congenital aortic valve. It's a bicuspid aortic valve. According to AHA guidelines, we all are aware about the indication of the aortic valve replacement in aortic stenosis. It is this is primarily critical aortic stenosis. Aortic stenosis in symptomatic patients with a bad LV or LV enlargements, or with a concomitant another cardiac procedure. The indication AHA, guidelines in aortic regurgitation are same. I'm not going into the details. In case of the mitral valve, the commonest etiology is the rheumatic heart disease. Yeah, unlike in the West, where the rheumatic heart disease is almost obsolete, and it is followed by ischemic heart disease. Now the indications: the critical mitral stenosis with the area less than 1 centimeter square. And then coming, briefly to the history of the cardiac valves. The first heart valves were implanted heterotopically into the descending aorta in 1952. And if we see the advances from the implantation of the valve into the descending aorta into the high profile valve, and now we are able to implant the low profile valves. These are the basic types of the heart valves. And these are the prosthetic heart valves. On the left, this is a ball and cage valve, a very high profile valve, the tilting disc valve, and the bileaflet valve. And here are the bioprosthetic valves made out of the animal tissue, the human tissue homograft. So it could be a porcine heart valve, or else it could be a bovine pericardial heart valves. Now, these are the three types of valves which I had spoken. These are the valves used in the past. I'm not going into the details. Now, this is the anecdotal picture, which it is never used nowadays anywhere in the world. Three high-profile valves inside the heart at mitral position, at tricuspid, and the aortic position. These ball and cage valves are obsolete. This is FDA approved heart valves, the mechanical valves. The most widely used valve is the St. Jude heart valve. The basic advantage of a prosthetic heart valve is its durability, but the disadvantage is it is thrombogenic, and therefore it requires anticoagulation. Now this is a bioprosthetic heart valve, and these are the FDA approved bioprosthetic heart valves: the Hancock, the Carpentier Edward, the Mosaic, and the St. Jude Biocor stentless valve. And the basic advantage in a bioprosthetic heart valve is it is almost non-thrombogenic, and therefore no anticoagulation is required. It is especially advantageous in a pregnant ladies, or in the patients who are unable to monitor their PT INR because also socio-economic conditions. But the basic disadvantage is the valve degenerates, and there are high transvalvular gradients. The, the major problem of collagen degeneration and calcification are being overcome now. So these are the bioprosthetic valve. Now the efforts are there to increase the effective orifice area and to have a longer longevity so that they degenerate at a later date. This is a very important slide. It shows the mechanism of failure in a bioprosthetic valve. It is always this thing gradual. It is in months or years. Unlike in a mechanical valve, if it gets blocked, the patient not have time even to reach the hospital. So this is stentless heart valve. Now stentless heart valve like homograft, they are especially advantageous because they have a very less transvalvular gradients. And they can also be used in presence of infection. But actual difficulty, the practical difficulty is they are not readily available on shelf, and the reoperation is difficult. Now the first operation for heart valve replacement is the Ross's operation, in which the patient's own autograft, the pulmonary valve is implanted into the aortic this position, and in the pulmonary position, the homograft valve is implanted. So the patient has excellent, almost natural results, and no anticoagulation is required. Now practically it can be done in all the ages, and contraindications are actually this thing theoretical. The advantage, it has a viable aortic valve, so it can grow with the patient's age. It has improved durability, and no anticoagulation is required. Therefore, absence of thromboembolism and anticoagulation related hemorrhages. The disadvantage, it's a longer operation, and we have to follow up the pulmonary valve. Now, coming on to the results, the mortality has steadily been decreasing over the ages, and this is the mortality of the combined aortic, the heart valve and the CABG. Now the age of operation is also steadily increasing in patients, above the age of 70 years. Now the basic morbidity is because of the thromboembolism and the bleeding. It is about 0.2% per patient year. The traditional risk factors for developing thromboembolism, we all are aware, and they are AF, increased cavity size, hypercoagulability. I will skip this slide. And more the number of risk factors, the more are the chances of thromboembolism. As I had already stated, the Ross's operation is the ideal operation. And if we see the valve, even after 8 years, the actuarial survival is over 95%. So how do we select the ideal heart valve? Yeah, there are many points, but the important and the relevant are, it should be durable, it should be this thrombogenic, and no transvalvular gradient is there. So the options available are for prosthetic, bioprosthetic, homograft, or the autograft. The treatment option, the best is the valve repair. But as I had stated, in India, the patients will come to us often extremely weak, and the valve is almost calcified, and it is impossible to repair that valve. So the other option is this thing, Ross's operation or the homograft. But in these, we have to have the availability of the homograft bank. So the only option left is a prosthetic or a bioprosthetic valve. Now, as we see, the failure rates of the bioprosthetic valve after 10 years are maximum in the younger age, and at least as the age advances, because of the metabolism of the body. This is the same. As I had already stated, the hemodynamic functions are the best in the Rosses and the homograft. How do we decide the valve? It is, because of the possibility of the future pregnancy, the contraindication to the anticoagulation, the LV cavity size, and the most important here is the socio-economic and the education status of the patient. Now, the mechanical valves, they have excellent durability, but they require this thing, anticoagulation, and therefore non-cardiac operations, it may be hazardous. Here, we do not need anticoagulation, but other operations are, and they are noiseless. Now, briefly into the progress. It is into the field of the minimally invasive heart operations in the valve, and they are heart port operations, the beating heart operations, the
Dr. Khanna, kindly wind it up, sir. Time is almost over.
Yeah, just 2 slides more. So this is the heart port operation. Here we cannulate into the groin, and the scar is here. The sub memory. This is a coapsis device in which on a beating heart we can do the anoplasty, and as we see, the amount of mitral valve repair is excellent on a beating heart. And this is Robert, as we have already heard about it. The console and the telearms of the Robert, and this is the this cutaneous aortic valve implantation, in which the hybrid approach is there between the cardiologist and the surgeon. And this is a small video of the mitral valve. Here the heart has been cannulated, the left atrium has been opened, and if we observe, the mitral valve is extremely calcified, and there is hardly any scope for the repair of the valve. The valve is being fixed. And the calcium debrided, the heart is arrested, and the heart functions are being taken care of by the heart lung machine. And here we are going to implant a bi-leaflet valve, the St. Jude valve. And here is the valve, and this is to dear the heart, and the heart is back to the normal activity, and we have weaned it off. This we are trying to take off the air heart. It should not embolize in the brain. I'll just, I think. So to conclude, the choice of the heart valve is tailored to the patient's, and it depends upon the age, the probability of the future pregnancy, and other comorbidities. Thank you.